Welcome to Jill Pearson Profiles. I'm your host, Jill Pearson. Our guest today is Professor Barbara Sahakian, who is visiting from Cambridge, England. She's Professor of Clinical Neuropsychology at the University of Cambridge, Department of Psychiatry, and the MRC Wellcome Trust Behavioral and Clinical Neuroscience Institute. She's also an honorary clinical psychologist at Adam Brooks Hospital in Cambridge, UK. She's president of the British Association for Psychopharmacology, and she's co-author of the new book, Bad Moves: How Decision-Making Goes Wrong and the Ethics of Smart Drugs. The book will be out in the USA in May from the Oxford University Press. Professor Sahakian has an international reputation in the fields of psychopharmacology, neuropsychology, and neuropsychiatry. And I want to thank you so much for being here today, Barbara.
Thank you, Jill. It's my pleasure.
And your co-author, Jamie Nicole Labuzetta, is at Harvard now.
That's correct.
She
yes.
started out in Cambridge with you.
She did. She did a master's degree with me, and then she came back to America and trained as a neurologist. So she's working at the Harvard teaching hospitals.
Okay. And tell us what smart drugs are.
Well, smart drugs are cognitive enhancing drugs, so they boost our thinking and our problem solving, our planning, our attention, those sorts of cognitive processes, as we call them. And there's a number of different kinds. So there's certain ones which are like the cholinesterase inhibitors, which is things like Aricept and Epizil, which we use to treat Alzheimer's disease now, and I did some of the first work on those drugs to try to bring them to market. So I published a long time ago in the Lancet on the cholinesterase inhibitor drug Tacrin for Alzheimer's disease, and I published that in the Lancet some years ago, showing that it improved attention and concentration in mild Alzheimer's disease. And then there's other groups of drugs, such as the drug Ritalin or methylphenidate, which enhances dopamine and noradrenaline in the brain. Those are chemicals in the brain, neurotransmitters. And so that's a drug that's frequently used for attention deficit hyperactivity disorders, you probably know.
Yes.
It's quite a common drug. And then there's other newer drugs, such as modafinil. And modafinil was first licensed in 1997 in the UK. For narcolepsy, which is excessive daytime sleepiness. And we don't really know how that drug works, but it does seem to have actions on dopamine and noradrenaline, and also on glutamatergic function, though. So it seems to have several different actions, and we're not quite sure how it exerts its cognitive enhancing effects.
But somehow they found that this worked for people who had narcolepsy and kept them awake?
Yeah, so, people who have narcolepsy, as you know, tend to doze off suddenly without any notice, and they could be right in the middle of speaking or something, and it does keep them awake and alert. But it's also, in the USA, it's also for sleep disturbance due to shift work, because they found that modafinil reduces accidents in shift workers, so it's regulated for that here as well.
Oh, so if people work the night shift, then they can use modafinil to be awake while they're working when a person would normally be sleeping.
That's it. So if they've been having trouble with their, routine due to having to sleep during the day, which is, something that we're not used to doing, they can take it. And actually, interestingly, we did a study in Cambridge with we tested some sleep-deprived surgeons who were based in London with Lord Aradazzi, because he was interested in whether he could keep his surgeons awake and alert and minimize any kind of side effects from them taking too much caffeine or coffee, such as the tremor that you get. And what we found there was that actually modafinil was much better than placebo in keeping these sleep-deprived doctors alert, and so they had less impulsive behavior. And when they had to solve difficult problems, they were very good at it. They were able to be cognitively flexible, so if they didn't get the answer the first time around, they were very quick at figuring out what the answer was. But the doctors who had placebo were much worse.
The placebo being an inactive pill, so
they
right. Didn't know which one they were getting.
That's right.
Yes.
It's double blind.
So do those surgeons or whoever who want to use the modafinil, do they have to have a prescription?
Yes, it's a prescription-only medication at the moment, but I'm concerned about that, and that's one thing we do raise in the book, Bad Moves, because especially in the UK, people are buying these drugs over the internet, and it's a very unsafe way to get your drugs, prescription-only drugs. You shouldn't be buying them over the internet because you don't really know what you're buying. It could be anything. And also, a lot of people don't take advice from their doctor, obviously, so they don't know whether the drug's counter-indicated for them, whether perhaps they have high blood pressure and shouldn't be taking it, or perhaps they're taking some other medication which might interact with it.
Right.
So it's quite dangerous to buy these drugs through the internet.
And I was very surprised when I read in your book how many people are already using modafinil.
Yeah, I mean, certainly modafinil is very well used, and here in the USA on college campuses there's been a number of surveys, and usually the figure that people come up with in the published surveys is 16 to 20% of college students on the college campuses are using these cognitive enhancing drugs, mainly Ritalin.
That amazes me.
Yeah.
Oh, but of course, so people know about Ritalin because a lot of people grow up taking Ritalin. So then they go to college and they have Ritalin and they share it with their friends?
Yes, it's been around for a long time, and I've talked to several different different college academic professors, and they say sometimes if you go in the library, you'll see people, passing over drugs to other students. Sometimes they sell them, sometimes they give them away. But some of them might have a prescription or have gotten hold of the drug in one way, and then they'll be, passing it out in the library or something like that. So, yeah.
Well, there are differences between Ritalin and modafinil for that kind of use. Wouldn't you be concerned about Ritalin?
Well, Ritalin, one problem with it is that, of course, it's a stimulant drug.
Yes.
And Dr. Nora Volkow, who's head of the National Institute on Drug Abuse here in the United States, is very concerned with, the substance abuse potential of stimulant drugs. And some people are using also Adderall, which is amphetamine salts, for cognitive enhancement purposes. And so she's very concerned about that aspect of it. At the moment, people have studied modafinil. It doesn't seem to have abuse potential.
So it's not addictive, although the Ritalin and the Adderall could be addictive?
It could be. I mean, Ritalin for children, when it's given to children for attention deficit hyperactivity disorder, it's usually a slow release preparation, and of course it's given orally. Now, Dr. Nora Volkow herself has shown that really the rush that you get is what promotes addiction, and that's usually you get that rush via a fast entry system. So either when you inject the drug or when you sniff it, as you might do with cocaine, another stimulant drug.
Oh, so Ritalin is being abused?
Yes.
For recreational purposes?
Well, we have to separate the recreational from the cognitive enhancement purposes, because you do get a mild euphoric effect, some people report, from Ritalin, but people who are taking it on college campuses for cognitive enhancement purposes are usually taking it to cram for exams, or maybe because they have to write a really long essay. And frequently, professors report, well, some students who typically would use it haven't steadily worked throughout the term, and then it comes to the end of the term and they have exams, and so they use these drugs to cram for exams and stay awake and alert for long periods of time, which of course is also could be counterproductive, because we consolidate our memories during sleep, so you don't want to find that you're taking Ritalin so much that you're disrupting your sleep at night.
Right, and one thing you mention in the book is that it's probably better to get a good night's sleep before an exam than to stay up and study all night.
Exactly. So it is a concern, the way that these drugs are used. But, I found that my fellow academics were using them. I traveled over to Florida to go to a conference, and I had to speak in the late afternoon. And I said to my colleague, I turned to him and I said, I feel a bit jet lagged, and it's a shame they're putting me in the late afternoon. It would have been better if I spoke in the morning. And he said, would you like some of my modafinil? And I said, "Oh, do you use modafinil?" He said, "Yes. For jet lag, I use it all the time." So then when it came to the tea break, I sort of was asking people, do you use modafinil? And somebody said, I use Adderall. Somebody else used Ritalin. Somebody else used modafinil. So I actually did a survey from the people that I was speaking with, and they sort of snowballed on the survey. And I found that quite a few of my colleagues were using these drugs, and I published that paper with Sharon Marin Zamir. We published it in Nature, called Professor's Little Helper.
Professor's Little Helper.
Yes.
That's shocking.
Yeah. And then Nature did their own online survey,
mm-hmm.
and they found that 1 in 5 of the people who responded to their survey were taking cognitive enhancing drugs. So
I had no idea.
Yeah.
But there also are many benefits of these drugs for the mentally ill.
Oh,
you
yes.
mentioned people with Alzheimer's, but also tell us how they can help the people who have mental illness.
Yeah, so with neuropsychiatric disorders such as Alzheimer's disease is straightforward. Everybody understands the cognitive problems that those people have. But of course we also know that in attention deficit hyperactivity disorder, many people, it's a lifelong condition, and if you can't focus and do well at school, you don't have very good prospects in life. So it's important that you can attend at school and pay attention to the information and take it in so that you get educated. And then also, as these people grow up, about 50% of them still have ADHD as an adult. And so they wouldn't be able to hold down a job because they wouldn't be able to, organize themselves, plan effectively and that sort of thing within the work context if they didn't take some medication. Mm-hmm. So I'm talking about, of course, the moderate to severe end of the spectrum, not the mild end of the spectrum. For mild ADHD, especially in children, you would use cognitive behavioral treatments mm-hmm. or some other sorts of treatments. But it's very important. And then I work a lot on patients with psychosis or schizophrenia, and they, of course, we do have neuroleptic drugs which treat what we call the florid symptoms, this psychosis or the hallucinations and delusions mm-hmm. that we're aware of. And they treat them rather well, the antipsychotic medication, but these patients are still left with, cognitive impairments, and that's what stops them from going back to university if they've had to drop out of university when they became ill, and mm-hmm. stops them, leading a normal, productive life of, having a good functional outcome, holding down a job, having a family, and that sort of thing. So that if we could treat them, improve their cognition, that would be very good. And we have been using modafinil as an add-on to their antipsychotic medication to try to boost their cognitive function there.
And are you seeing good results?
We're seeing very good results. So that's with Peter Jones and Linda Scoriels, and we've been looking at both first episode psychosis and also chronic schizophrenia. Mm-hmm. And as an add-on, and certainly for cognitive flexibility, we've seen them almost normalized, really. So that's very encouraging.
That would be revolutionary.
Yeah.
If schizophrenics could be normalized and have a regular life. Then.
Yeah, absolutely. And in schizophrenia, they frequently talk about negative symptoms, and those are such things as, not really being able to do anything. So it's a kind of apathetic type of thing. Mm-hmm. We see apathy in other areas in patients with brain injury or in normal pressure hydrocephalus. And we have been able to show that in healthy people, if you give them modafinil, it improves their task-related motivation. So they enjoy whatever they're doing a lot more. So, and a lot of people do report they take these cognitive enhancing drugs to do tasks that they've been putting off and they haven't really been looking forward to. So these drugs could be very valuable not only to boost such things as attention, concentration, planning, and memory, but also to improve task-related motivation.
That's so interesting. Can you tell us a little bit about the decision-making analysis that you talk about in your book? What's the difference between hot and cold decision making?
Yeah, so it's a very important area and very interesting because, of course, so much of what we do every day is decision making. So if we have impaired decision making due to depression or due to brain injury, it really is very debilitating and affects our ability to function in daily life. And so the cold cognition or cold decision making is the type of thing where, as you're sort of planning out your day or maybe planning this interview, you might think, well, how am I going to start? I think I'll start with this question and then we'll move on to that, and maybe I'll look at this reference to refer to something else. And so you'll have quite a lot of time and space, and you'll be organizing yourself. And then maybe we get in a situation, and then sort of it starts to get out of hand, and it's not scripted or anything. And then suddenly you want to ask a question, and maybe it's a very a bold question to ask. So it could work out really well, but then maybe it would be a mistake later on. So that's the sort of hot decision making. And I frequently use other examples where you might just be planning your day and what you're going to do so that you get the best out of the day, and you're organized as much as possible, and that's cold decision making. And then hot decision making might be the type of thing where, say, a student at university has an exam the next day, and his friends say to him, well, let's go out to this restaurant and relax a bit, and guess what, this girl that you like very much is going to come along with us, so you get to meet her, and you've been looking forward to that. And then this young man has to think very quickly, am I going to do that and risk being sleep deprived and not doing so well on my exam? But then I could meet this girl, and that's very appealing. So it's usually this tension between a lot to gain, something very rewarding, but also something very risky. And you have to make it in a time-limited way, so you don't have a lot of time to make those decisions. It's almost like a gut reaction situation.
And there's emotion involved.
Exactly. So one's more rational and one's more emotional.
I see. So tell us how you found that decision making goes wrong in some depressed patients.
Yeah, so we know that depressed patients frequently report to you that they have trouble making a decision, a kind of indecisiveness. Mm-hmm. And what we did was we actually did objective measurement of this, and we found that it took them really much longer to make decisions than, say, a healthy person would. Mm-hmm. And that seems to reflect this problem of, probably inner rumination. Is this a good thing to do? Should I be doing this? And really having trouble actually coming to a decision. And of course that's very debilitating, because if you go to work, you have to be making decision after decision after decision, and you can't spend, hours over one decision. You have to move on to the next one. And so, as you know, frequently in depression, people are off work, they're absent from work, and sometimes they come back to work, but maybe they're not able to be as productive. So that's called presenteeism. So in depression, we have both absenteeism and presenteeism sometimes.
Oh. And is it the hot or the cold decision making that goes wrong?
Well, in that case, it's related to the hot decision making in that particular task, but you can see it under other circumstances where they have, what we call a psychomotor slowing. They just find it difficult to think at the same pace that you or I would think when they're depressed. And one thing that I'm very keen about is that with these neuropsychiatric disorders like depression, we have to try to get people to come early and report that they're not feeling well, so that we can detect it early and treat it very effectively first on, because I think then they would have a much better trajectory, because frequently in depression people will have a bout of depression, they might be off work, and then they come back to work, but then they might be off again. So it becomes what we call chronic and relapsing. Mm-hmm. And lots of times that's because people don't seek help early on, and by the time they come for help, they're really very ill. So we need to really identify these conditions early on so people can have a good quality of life and functional outcome.
Well, can someone be chronically depressed for years and not realize it?
Usually it will come to other people's attention. I mean, usually family members will have recognized it by that and bring them in. But depression can present in other ways. In younger people, for instance, it's often, aggression or hostility. So it doesn't always present in a typical mm-hmm. way. But it's usually just that it creeps up on people. And the other thing is that we all have bad days. We all feel sad or whatever. But having it go on consistently and get to a point where you don't take an interest in things that used to interest you anymore. You don't even take an interest in your family members. then you really need to make sure that you seek help or somebody helps you seek help. But most of these illnesses, 75% of mental health problems start before the age of 24 years. So really we should be thinking about good brain health in everyone, and how can we keep ourselves, fit in terms of our brain, because we think about good physical health all the time and screening for it, or certainly we try to take exercise, eat well, and some of these same things are good for your mood. So for instance, exercise is fantastic for your mood, and of course it's good for your cognitive function, and it's good for your physique. So that's something where we could have good brain health if we thought about this early on, and we should look early on in people to make sure that they're well and that they stay well, and if they start to develop something, that we treat it quite early and effectively.
And what if the person themselves has no awareness of the problem, but their family does? How do they get the person into treatment?
Well, usually you can take them in because they'll begin to realize that they've changed. If you try to explain to them, you used to like to do this, you used to go out more, you used to be so active about this, or maybe they've had to be off work for a longer period of time, and so because they haven't been well enough to go into work, or maybe they don't want to, they're sleeping more, they're not getting up, and not taking an interest in going out. So I think the first thing to do is obviously discuss with them how they've changed, and try to get them to come around early. But if you have those discussions relatively early, it works out much better, because obviously once they get very ill, it's difficult to work with them. I've often been asked to treat somebody with cognitive behavioral techniques with depression, and sometimes when I've gone to see them, they've been so ill that I couldn't engage with them. I couldn't sort of suggest things. I couldn't talk about what their homework might be, what their strategies might be, what they should be doing, because they were so ill. So I have had to wait for their medication to actually bring them to a level where I could engage with them.
I see. Okay. And one other thing I thought of when you were speaking about the Ritalin, I know that there are some people who say children shouldn't take Ritalin because who knows what effects it will have on their developing brains. Ritalin has been around since the 1970s, so there must be children who took it then who are adults now.
Yeah.
Have there been studies done?
Well, the thing is that what we need is studies in healthy people that are long-term. We need the safety studies and efficacy studies and long-term studies in healthy people, because medications are obviously aimed at treating a disorder or dysfunction. So we haven't got these studies in healthy people. But you're quite right. I mean, we now know from the elegant work of Jay Geed and colleagues at the National Institute of Mental Health that our brains are actually in development into late adolescence, early young adulthood. So it's one thing if you have severe ADHD and you need treatment such as Ritalin in order to be able to focus and concentrate while you're at school and get on with your school work. But it's another thing if we're going to manipulate chemicals in a normally developing brain. So I think that's one thing that I am concerned about with this increasing lifestyle use of cognitive enhancing drugs by healthy people, because some of these people are probably of the age where their brains are still in development as well.
But your opinion of the use of Ritalin for children who have ADHD is that it is very useful?
It is very useful. It's one of the most effective treatments we have. ADHD is actually the most prevalent disorder in childhood for psychiatric disorders, and we can do quite a lot in the mild end of the spectrum with psychological treatments, such as cognitive behavioral treatments, especially behavioral treatments actually. But when somebody's really got a severe ADHD, it is recommended that you treat with medication, a drug, so that you get the best possible effects. In this country, they frequently use Adderall or Ritalin, but in the UK, it's mostly just methylphenidate Ritalin that's used.
Okay. And so have you tried the modafinil for depressed patients? to see how it affects their
decision
making?
I have not, but there are studies where they have looked at it, and it does seem that in some of the studies, at least, they've got very good effects. And again, I don't think they've completely measured things like reduction in apathy per se. They've been mainly looking at, changes in terms of the effects on the depression rating scales and so forth. But it does seem that it could be very useful in that context as well. And so there seems to be quite a few uses where you might have apathy, say in Parkinson's disease or some other condition where modafinil could be a useful add-on to other medications to reduce the apathy, get people out doing things, and also get them doing tasks that they should be getting involved in and that type of thing, and also boosting their cognitive function, because although people think of Parkinson's disease as a motor disorder, of course it has cognitive sequelae as well.
So a person who's suffering from Alzheimer's or Parkinson's could have a better quality of life, might be able to live at home longer.
That's right. So certainly that's what they've shown with the cholinesterase inhibitor drugs. So those drugs I mentioned before, like Aricept and donepezil, which are used for treating Alzheimer's disease, they do keep people out of institutionalized care for longer. So it's much better for the individual who usually doesn't want to go into institutionalized care. But it's also good for society and governments, because people have to pay. We have to pay for that.
Right.
Care, so it works out well in that regard. Now at the moment we just have symptomatic treatments, and when I did some of those early proof of concept studies with the cholinesterase inhibitors, I saw that they really affected concentration and attention and didn't really address the episodic memory problem that people have with Alzheimer's disease. So that's the type of thing where, suppose you park your car in a car park when you go into work or into the mall, and then you come out a few hours later and you think, where did I leave my car in this car park? Or
Please
maybe
don't tell me that's a sign of early Alzheimer's.
That's one of the first.
Who among us has not done that? Oh, Barbara. Okay.
Yeah, and another example might be you put your keys in the door when you're coming into your house or your flat, and then the phone's ringing, so you sort of chuck your keys somewhere and you rush over, answer the phone, and you go out a few hours later and you think, where did I leave my car keys? Where did I put them when I was coming in? Or your house keys, and you can't find them again. So it's that type of memory. So we need some good symptomatic treatments for that. And also now they're working on neuroprotective treatments. So they're not going to just treat the symptoms. They're really aimed at halting the disease process itself and stopping the underlying disease process, so that we'll have, we won't develop further. So those need to be put into patients very early on, so that they can have a good quality of life and everything, because you don't want to halt the disease process when somebody's already got severe dementia.
So the idea would be to start a neuroprotective drug such as modafinil as soon as the person shows the first symptoms, that would prevent the disease process from continuing.
Yeah, so modafinil is not a neuroprotective drug.
It's not?
No, it's not a neuroprotective drug. So these are newer drugs that are being developed for Alzheimer's disease. But you would want to put it in very early on in the stages we call mild cognitive impairment, which are the prodromal stages, or the very early stages of Alzheimer's disease, so that people can still be at work and have good quality of life and function in their home and social environment.
Well, that would certainly be a wonderful thing for those people and their families.
Some are in phase 3 clinical trials, so they may be out in the next 10 years.
Well, so that would be a wonderful improvement. I just wanted to ask you one thing. Have you studied, or do you know of studies of the effects of regular marijuana use by teenagers? What effect does that have on a teenage brain?
Yes, well, that's somewhat controversial, but people have seen that there's been some studies by Terry Moffat and her group, which has shown that it does seem to affect cognition if used long term. And there's other studies by Professor Murray at the Institute of Psychiatry, where he's shown also that if you're susceptible, say, to psychosis, if you have, say, a predisposition to it, it may actually trigger psychosis in young people. So that's something else to be worried about. I've actually looked at another drug with a then student of mine who's now a reader at University College London, John Royzer. And what we did was we looked at ecstasy, because in the UK people were raving at the weekends and taking ecstasy chronically. And what we found there was they frequently got these midweek lows, and some people actually got depressed. So we were wondering, because we know that ecstasy lowers your brain serotonin, and that we need our brain serotonin for our normal mood regulation. So, and the SSRIs, selective serotonin reuptake inhibitors like Prozac, are used as treatments for depression. So we simply asked, if you keep taking ecstasy, will you, essentially lower your brain's serotonin and make yourself depressed? And we found that you would, but only for those people who had the SS allele of the serotonin transporter gene.
A certain gene.
A certain gene.
Yes.
So there's this interaction of the drug with the gene. And of course, that's called pharmacogenomics, and that's going to be very important for drug development.
I know, and I'm sorry to stop you on that interesting point, but we're out of time. So our guest has been Professor Barbara Sahakian from the University of Cambridge in England. Thank you so much for being here, Barbara, and we'll see you next time.
Thank you, my pleasure.